Thanks for inviting me today. It's great to see so many people in the audience. It was great to have Dr. Taylor. It's great to have the Ontario Ministry folks, and Donna's here. It's like old home week a little bit. So I'm an alumnus of the Public Health Agency, and I'm an alumnus of CAN-FASD Research Network, and so I've worked with so many people, and I've been so lucky to be able to do that in my career. I think I've never held a job more than 3 years. So I'm on 2 years now at the SOGC, which has been really fantastic, and there's so much to do that I can't even possibly think about leaving. And it also allows me in my scientific director role to still, as I say, mess in the world of FASD, because alcohol in pregnancy is a very important topic for the Society of Obstetricians and Gynecologists of Canada. So what I'm going to talk to you today about is all work that's actually been supported by the CAN-FASD Research Network through its provincial partners, which are the northern and the western provinces in New Brunswick. There's some openings if Ontario wants to try out, and also through the Public Health Agency over the years. So I was asked to talk about the new diagnostic guidelines, which I will do, in the context of using screening, diagnosis, and data to improve outcomes related to FASD. So I'm going to talk a little bit about why diagnosis is important, and I'm sure you all know that, so we won't spend much time on that. A little bit about data, some about the revision project itself, involving the clinical survey that we did, talking a little bit about the guidelines themselves, and a little bit about training. So why do we want to diagnose FASD? We know that it's important to receive a comprehensive assessment about the individual's strengths and weaknesses, about their domains of impairment. Information from diagnosis is important to be able to improve outcomes through matching interventions. Accessing support services. We know from Anne Streisguth's data from 1997, I think, that diagnosis before age 6 improves outcomes. We know that a trained multidisciplinary team is really, really important. The data also show that. And we know that it's also helpful to collect standardized data related to diagnosis. Because otherwise, if everybody's not collecting the same thing and talking the same language, it's really hard to get statistics and rates and prevalence and information for folks to be able to make decisions on. So what we did, many of you know Dr. Sterling Claren, who was really the brainchild isn't really the right word, but behind the Universal Data Form project. And this is what we did as part of the CAN-FASD Research Network to start to see if we could collect standardized data across diagnostic centers in Canada so that we can start to look at prevalence and we can start to, again, use the same language across this country. And again, that is going to inform diagnosis and the diagnostic process leading up to the revision of the diagnostic guidelines. So we did this data form project, which really provided the first accurate spectrum of functional diagnoses and treatment plans across clinical practice internationally, worldwide. So the Public Health Agency funded a pilot project. Can we even get clinics to collect the same data? So we had 45 clinics in the country at the time. Now there's over 60. We worked together with those clinics across the country in consultations to develop these data forms, which were kind of unwieldy. And we collected information about demographics, diagnoses, what kind of diagnostic scheme was being used, what the brains looked like in terms of domains of impairment, other diagnoses, and also what kind of recommendations were made for interventions and management, as well as any kind of other associated deficits, problems, challenges that individuals had. And we did this for both adults and children. Here's kind of what the forms looked like. It's a bit old school. You kind of remember those Scantron forms in like the 80s and 70s where you had to fill in little bubbles, and that's what happened here. There was also a web-based version, and we collected all kinds of information. And this is what it kind of looks like in terms of the brain domains, hard and soft neurological signs, imaging, whether they're significantly impaired, mildly impaired. So we had 307 forms, 289 had confirmed diagnoses, 18 diagnoses were deferred. So we basically have a database of 289 diagnosed individuals with FASD right now. This is some of the data, the demographic data. You can see that only 4 provinces were able to participate because the ethics process was a bit unwieldy as well. And so we have data from those 4 provinces. We did publish this paper recently, so it's out there in the literature. And I just want to show you that this gives us our first little glimpse at actual prevalence. And what we're showing in terms of, this is the old system, but in terms of the diagnoses, you can see the important thing. Do I have a pointer thing on here? I wonder. Anybody know? A little light? No. Nope. Okay. So 79%, see the big 79% pie? That means that 79% of individuals in our database were actually were diagnosed as and met criteria as for alcohol-related neurodevelopmental disorder. The important thing is these individuals had no facial features or physical features associated with prenatal alcohol exposure. And that's about what we would expect from the literature. And that also is showing the invisibility of this condition or this syndrome. And so when I do talks and I talk to physicians and health providers, I talk a lot about the fact that folks, 80% of the individuals in our database and across in other studies look absolutely like we look. There are no physical features, and that's really important in terms of recognizing the impacts of prenatal alcohol exposure. And we have to do a much better job at educating frontline workers, service providers, health practitioners, folks who interact with individuals that are affected by prenatal alcohol exposure about what the behavioral characteristics are and the implications are in the context of their environment, so that we can help everybody engage better, provide appropriate programs and interventions, and have appropriate expectations and definitions of success and outcomes. So this is really neat. This also shows that the number of brain domains impaired. So when you do diagnosis in the old system, you looked at 9 potential brain domains that could be impaired. You can see that over 20% of the individuals in the database have 6 to 9 brain domains impaired. That's really significant. Anybody know how many brain domains for impairment you need to receive an FASD-related diagnosis? 3. Look at these, 6 to 9 brain domains. These individuals are extremely impaired. The really interesting thing is that there's 25 to 35% of individuals received an FASD-related diagnosis with less than 3 brain domains impaired. That's interesting. So anyway, we haven't kind of figured out why, but it's interesting. No data is perfect. This shows you just the brain domains that were significantly impaired, and this wouldn't be a surprise to anybody related to ADHD and adaptive behavior and executive function. These slides are all in your syllabus as well. So what we really wanted to see was, is there a pattern of common brain domains that are affected in individuals with different numbers of facial features, with different interventions that were recommended? Is there some kind of a pattern that's emerging? Because then we can say, okay, most individuals who have these characteristics have this kind of a brain package, and here's how we can best improve their outcomes and match services. Nada, nothing, 0. There was absolutely no correlation and no kind of pattern of brain dysfunction. So, I just lost my train of thought. I'm getting old. So we took that information and said, well, again, it's not that surprising, given that the continuum of prenatal alcohol exposure is so vast and that alcohol has such pervasive effects. Given that we didn't know about drinking patterns and timing of exposure and critical periods and things like that in terms of prenatal alcohol exposure, we didn't know levels of alcohol in the database, then that wasn't that surprising when we started to think about it. However, the data did show us that adults had a lot of life challenges, mostly with substance use, with smoking, victims being victimized, not finishing their education, and 63% were legal offender and half were legal victim. So this is beginning to get some actual data and evidence related to some of the challenges that adults with FASD had. And we did this because the field is really lacking in data and evidence for this. And so this is the start to kind of catalyze getting more data and information related to this. So here's what I was really asked to talk about. I wanted to tell you about Dataform because I think it's important. I think it's informed by diagnosis, but it also informs diagnosis. It's collecting data that we can use together as provinces, as countries, as families to be able to better plan for services, supply and demand of services, and interventions to be able to help better understand our FASD population in Canada and to be able to hopefully use the information to improve outcomes. So we're actually relaunching the Dataform project. It was funded by NeuroDevNet over the next 3 years. We have a lot of clinics who, I think 48 have expressed interest. We're working with those clinics to try to develop a Dataform that's going to provide data and information that's useful to provinces, that's useful to clinics, and that's useful to hopefully to families as well. And so we're currently working on that. We're having our second teleconference of interested clinics in a couple of weeks, and we're starting to roll that out. We had to revise everything according to the new guidelines. So back in 2002, we started the process of the first Canadian diagnostic guidelines, which about killed us all. We lived to survive it, and they were published in 2005. And you know what? They weren't perfect. They're guidelines. They're not laws. They weren't perfect. It was the first attempt to try to kind of come together and agree on terminology and language and process. It started a lot of work, chatter, fallout, research in the field, which was fantastic. And so if you don't do anything, if you don't take the risk and get things out there, nothing's ever going to happen. So we took the risk, we get them out there, and a lot of work happened over the next 10 years because of that. So in 2014 or 13, the Public Health Agency said, you know, we really need to update these, which we knew. And so they kind of coerced us into doing this again, which also took 10 years off our lives, but that's okay. So really what we wanted to do was say, okay, we have a lot of experience now. We now have data. How can we improve the diagnostic guidelines based on evidence so that we can improve the diagnostic process and, again, improve outcomes? So we know that there are a number of systems. There's the 4-digit code. There's the Institute of Medicine, or the IOM criteria. Jean Hoyme has a system. Emory University with Claire Coles has a system. And then there's we Canadians. They're all a little different in certain ways and in certain aspects. And we're working internationally to try to come up with some international definitions in terms of terminology. And during the diagnostic process, we worked really hard to say, how does our system translate into other systems? And we would actually look at data and say, if we did the diagnosis this way with these criteria, how would this shift the number of individuals who received a diagnosis versus not? So there was a lot of playing around with data because that's how you have to make these kinds of decisions. So Claire Coles actually just is about to publish a paper in Alcoholism Clinical and Experimental Research comparing these diagnostic systems, and it's really fascinating. So we knew that there were gaps and inconsistencies in the initial guidelines. We knew that we needed clarification on processes and practices. We knew that we had to address diagnosis for infants and adults as best that we could. Back in 2002 to 2005, there was very little evidence that could support recommendations for diagnosis for infants and adults, and that has changed somewhat. We knew that we had to reflect sound evidence-based recommendations. The evidence is really important. When we develop guidelines and make recommendations, they can't be based on intuition. They can't be based on kind of, we sort of know that this works because we've been doing it for years. We have to be able to provide evidence to be able to support our decisions, because this is what the field looks to. And so as researchers and scientists, we're really take it seriously to be able to get our work out there and published so that it can really help to form the foundation of evidence on which we base recommendations and decisions. We have to be able to quote studies and data. We can't just quote our own brains as much as we would like to. So what did we do? We did a very comprehensive literature review, which is a companion paper that we haven't yet published. But we will. We talked about gaps, concerns, limitations. We did a survey to all the diagnostic clinics in Canada and got their input. We had meetings, conference calls. We had a steering committee of experts from Canada and the US. We had a national and international workshop where we had 75 folks who came together and spent 2 days talking about and hammering out the specificities around diagnosis. We had meetings all over the country with clinicians and allied health providers and diagnosticians, researchers to really, like I said, slice and dice data to make sure that we were making recommendations that were sound. We came up with this draft guidelines. We talked about them at conferences and meetings and workshops. We sent them out for review internationally to experts around the world and said, how do you feel about this? What are your thoughts? What are your suggestions? And so when it came time to publish in the Canadian Medical Association Journal, it took 8 months for them to review the paper because they couldn't find any reviewers that weren't in conflict. So I actually think that's a good thing. You don't make everybody happy, but you do the best that you can. So now what we have is we have published in the CMAJ the executive summary, which is only a piece of the guidelines themselves, because it was going to cost $120,000 to publish the actual whole guidelines. We did write a companion review paper that we've yet to publish. Another group wrote an anticipatory guidance paper for general pediatricians that followed the guidelines. And also there's folks from Alberta who are working on a companion kind of piece to provide some guidance around prenatal alcohol exposure in the guidelines. And the CanFASD's Family Advisory Committee is going to write a paper to help families understand the implications of diagnosis and the diagnostic process. Because, again, these are diagnostic guidelines. They are meant to guide the medical diagnosis of FASD. Okay, so the clinical surveys that we did across Canada, most of them used the diagnostic guidelines. Some of them used some other systems. Some of them used a hybrid. Some of them collected information differently. Many reported that they already used at the time FASD as a diagnostic term, even though back then it wasn't a diagnostic term. Remember, it was split out PFAS and AR&D and ARBD, but they were just mostly using the term FASD as the umbrella term, as a diagnostic term. They thought it was easier to talk to families, it was easier to understand, and it made a lot more sense. We knew that they wanted more information about infants and adults. They really, really wanted us to recommend to use FASD as a diagnostic term. They said, we're not finding any evidence that growth is actually really impaired by prenatal alcohol exposure, and so we think that criteria doesn't really need to be part of the diagnostic indicators. It needs to be captured during the diagnostic process because it's important, but the evidence does not support it as a direct effect of prenatal alcohol exposure in a very significant way. Definitely clarity around the CNS assessment, central nervous system assessment, and brain domains, and then improved guidelines for determining prenatal alcohol exposure. And this goes back to a little bit about what Nancy said. How do we talk to women about alcohol? How do we collect the information, and who should do it? And this is a little bit out of the scope of the diagnosis itself, and so we're working on a separate project to be able to do that kind of So here's what we talked about a lot. We talked about prenatal alcohol exposure. We have a whole chart that we developed, and I'm happy to share that about all of the evidence in terms of what did they measure, where did they measure it, and what were the outcomes, what were the amounts, so that we could try to make an evidence-based recommendation. Because by saying significant alcohol exposure, you have to actually be able to try to define that, and it has to be based on evidence. We wanted to modify the domains. We talked a lot about DSM. Do we adopt it? Do we not adopt it? Do we go in super domains? I don't even know what that means, but it sounded like a good t-shirt option. There was a lot of chatter from the psychologists about relaxing the cutoffs, standard deviations. I am not a clinician, so I don't even sometimes understand that stuff. I'm just really bossy and a taskmaster. And so I say, all right, guys, make a decision, it's time, you know. We talked a lot about nomenclature and using FASD as a diagnostic criteria, and we always got stuck and we always went back to the evidence as best that we could. So there was controversy. It was not easy. It was not easy. We were often, folks were kind of saying, I think this, I think this. We'd go back out for consultation, we'd get all the information, we'd come back to the table, and finally, we were able to agree on kind of the recommendations. So basically, we kind of said, how do you get FASD? Well, how do you diagnose FASD? Basically, you have the facial features or you don't. I showed you the data that show most people don't have the facial features, right? The good news is that the facial features are very, very predictive of prenatal alcohol exposure. Like 95% predictive. So that means that if you have the full facial features of FASD, confirmation of prenatal alcohol exposure is not necessary. Okay, that is based on very strong evidence. However, most of the individuals we know don't have the full facial features, and that's where confirmation of prenatal alcohol exposure is really important. Hopefully in the future, when we have more data from the database, we'll be able to start to tease apart which facial features, how predictive are they of amounts of prenatal alcohol exposure and things like that. That's a research question. Then we said, so you can have the face or you cannot have the face. And then there can be this other category of folks that we don't want to lose in the system. Those are the at-risk individuals. So we know their brain's not quite right. We know that there's been some prenatal alcohol exposure, but they don't quite meet the criteria for diagnosis. Okay? It could be that it's not available. It could be that they're too young. It could be that they're, have other issues that are more pressing, but we don't want them to get lost in the system. And so that's why that designation was added. It's not a diagnosis, it's a designation. So here's basically what it looks like. Nice and easy. You gotta have the face or you don't. You have prenatal alcohol exposure required or you don't. Okay? Makes sense. So what do we change overall for the diagnostic guidelines? Growth was removed as a diagnostic criteria. Again, doesn't mean it's not important, but it's not predictive enough of prenatal alcohol exposure and FASD. The Americans are also doing the same thing, so it's not really going to be a 4-digit code anymore. It'll be a 3-digit code. Prenatal alcohol exposure level associated with risk of physical or developmental implications was defined on the best evidence that was out there. Criteria for diagnosing infants were added, and special considerations for diagnosing adults were also added. So this is all the medical kind of pieces of it, but I just wanted to show you that there's some domain, brain, name changes, name, brain, domain changes. Hard and soft neurological signs is now called motor skills. Brain structure is called neuroanatomy and neurophysiology, and that was a whole day's conversation. Communication was changed to language. We had a lot of input from speech and language pathologists. ADHD was renamed attention and redefined, and there were lots of reasons and lots of discussion, and again, like I said, lots of looking at the literature, looking at data, and talking to other researchers and clinicians internationally to be able to figure out if this kind of made sense. We tried to be congruent everywhere we were with other diagnostic systems. It only makes sense. Let's not try to reinvent something new. Let's not try to try to rename, things that are irrelevant to other contexts and other countries. And so that's why we did this extensive international consultation. So we did, but we had a little bit of trouble with the DSM and figuring out how we could try to be, I guess, comparable and complementary to the DSM, which wasn't easy. We added affect regulation, which I guess I'm hearing is a little bit confusing to the field, so we'll let the psychologists figure all that out. And then we had a lot of discussion around sensory processing, and we got a lot of angry emails about that. But that's where we are. So you can read the diagnostic guidelines in CMAJ. Again, they're very clinical, they're very medically focused. The executive summary is easier, I think, for everybody. And we're going to be developing, the Canada FASD Research Network is working with partners to develop some kind of so what pieces, which I think are really important for the public, for families, and for government folks. We know, though, that we can't really just measure what we need for diagnosis to be able to make some kind of an impact and improve outcomes. Diagnosis is one thing, but having the full picture of the functionality and, like I said, strengths and weaknesses is really important. And so we do say these other things have to be measured to be able to best meet the needs of individuals and families, and they include things like growth, anomalies, morbidities, birth defects, sensory issues, sleep, and as Nancy suggested, some of the pre and postnatal factors whenever we can get them, because we know that preconception health is important, we know that epigenetics is important, and how does this affect vulnerability for fetal growth and development to any kind of insults, including the teratogenic effects of prenatal alcohol exposure, which I think is really, really, really exciting. And I think I got Dr. Taylor excited about it too, which is maybe a good thing. So, and then we had the exciting idea, let's develop an algorithm and get somebody to help us develop an app. Because wouldn't that be useful for clinicians to be able to put things in and it says, if this, then this, and if this, then this? So we're trying to find some funding to do that. So this is what our algorithm looks like. And Courtney Green spent a lot of time moving and renaming boxes. But this is what the algorithm looks like right now. And it's also published as a part of CMAJ. We want to get it, laminated and things like that. So it's basically a whole summary of the diagnostic process itself. So we know that follow-up improves outcomes, obviously, and this is also a big part of the guidelines. And we had Jan Lutke helping us with this and going out to her network of families, and we also had some input from the Canada FASD Research Network's Family Advisory Committee. So we know that education and support is important. We know that using appropriate language, and we know that training is really important. And Nancy talked a little bit about that with SBR. It's also really important in terms of diagnosis and how important it is to have experience and training when you're doing this diagnostic process, because it's so complex and it's holistic. It's not just a small process. We know that we're recommending also that members should of the team needs to follow up, and you need to designate a member to follow up so it doesn't get lost in the system. Linkages to resources and services we know are important, and being able to provide a customized list of feasible services is also important. And the Canada FASD Research Network is working with the provinces in our network to be able to identify the services that are available in their provinces and have that information available for families by the clinics. So basically, all that together tells us we still have no safe amount of alcohol during pregnancy, no absolute number for how much alcohol is safe, and we still have no absolute number of how much alcohol is not safe, right? I've been in this field since 1992. We've been talking about it incessantly since then, and we still don't really know. And we'll still continue to do the research, even in the inbred mice who are identically genetic. We still find that there are differences in the expression and the outcomes related to prenatal alcohol exposure. Same amount of alcohol, exact same time of the day, inbred mouse strains, still there's a variation. So interesting though, eh? I miss my mice sometimes. Sometimes they're a lot better than dealing with people. So anyway, we digress. So preventing alcoholic pregnancies, we know the importance of it. I'm not gonna belabor that. We know that taking a reliable and accurate maternal alcohol history is the best screening tool for FASD. We know that. We've got to do a better job at helping folks be able to understand, as Nancy said, how do we talk to women? How do we create the relationship in the environment? How do we help understand the so what piece? And so this is where the Society of Obstetricians and Gynecologists can come in. We have 35 members who are perinatal care providers. These guys come to our CMEs and sit there as captive audiences because they need their education and training. And so by being able, that is a captive audience that we can ask questions to, we can provide training to. It's really exciting. And so we're working really hard to try to make that happen. And as well, we're doing a project that I'm not talking about, but called the Treatment Improvement Protocol, which is a really bad name for it. But basically, it's identifying when at-risk drinking may be a problem for women, pregnant women. What are the signs? What are the kind of indicators? And what do we do about it? Okay, so that's one. The other piece of that is, how do we identify that prenatal alcohol exposure may be a problem and may be impacting this person's behavior in my system or service? And so we worked on this with the substance abuse and mental health centers in Alberta. We did a pilot and we talked to the workers and they said, I suspect sometimes that this individual is affected by prenatal alcohol exposure because of the way that they're interacting. And, I know they're not trying to be a pain, but they really are. And so but I do things differently. I do things differently in my service because I know that it's going to make a difference for them. And so there's no data about that, though. There's really no data. And so we started a project where we worked with frontline workers in those two sectors to say, what are you doing differently? How do you know that prenatal alcohol exposure may be a factor? Let's train everybody to use a screening tool and let's help them understand how FASD is kind of presented by individuals in their environment. So if you're in a substance abuse treatment facility, an outpatient, and your patient doesn't remember to come to treatment, there's things that you can do to help that. And so what we're trying to do is say, here's what FASD looks like in your environment. Here's when you may think that prenatal alcohol exposure may be a factor. These individuals aren't diagnosed often. Here's what you do to do a screening tool. Here's the data you collect, and then here's what you do about it. And then what we want to do is try to help change the programs and service delivery to better match the needs of individuals with FASD and better improve outcomes. So we have to do the training, we have to do the education, we have to do the screening, we have to refer them for diagnosis, and we have to collect the data. So that's another whole project that's really exciting. But again, it feeds into diagnosis. So we have to screen, refer, collect data, right? That's the tip part. Then we have to collect the data in the data form project that's going to be useful to folks and send that data back to the participants. And then we have to also be able to measure the same thing and to be able to collect the same data, and that's where the diagnostic guidelines come in terms of standardization. Then we can start to measure prevalence. Then we can understand supply and demand for services. We can understand the implications of services and programs. We can better define outcomes and success for individuals who are affected by prenatal alcohol exposure, because we can better deliver the types of systems and services that are going to optimize those outcomes by how we redefine success. Does that make sense? So it's exciting. Not as exciting as mice, but almost. So I digressed a little bit, but I wanted you to see kind of the whole big picture of this. Has been years of work, probably since just these projects started probably in 2000 or 2002 maybe, and with the National Advisory Committee that Health Canada, before it was even the Public Health Agency, struck. And so that National Advisory Committee said, we think we need to do something related to diagnosis and screening, and that's how this whole ball started to roll. And then we just picked up momentum, and we, snowballed over other programs and projects and kind of sucked people into our vortex of FASD. But I want to, just to conclude by saying, these are, back to the diagnostic guidelines, these are guidelines, they're not laws. And this is, New Zealand called me, they go, we really love this, but this part isn't working for us. I said, well, don't use that part. Use what's working for you. Use what works for you in your context and in your environment, but for God's sakes, collect data on it, because we need it. So we wanted to make the guidelines not so prescriptive that other people, other countries, individual clinics, rural, urban, those kinds of things couldn't use them. And that's why we put in the piece that you don't have to have a physical clinic. You can have a virtual clinic. You can send things out for consult and things like that, because we know that it's not ideal situation across most of our country in terms of access to multidisciplinary, well-trained diagnostic centers. We know that. So what we tried to do, again, was not be so prescriptive, but be prescriptive enough that we could provide true evidence-based guidelines for folks to be able to follow, to be able to help with the diagnostic process, to be able to standardize the process, to be able to help with the decisions around the diagnostic process itself, and to be able to gather some information that's going to be useful. So we know that research continues to reveal discoveries that are going to improve technologies for screening, diagnosis, and treatment. There's lots to do. We know that data is important. You can tell I love data. I also love placentas. That's a whole other talk. Nobody ever asked me to talk about placentas anymore, which I'm... Oh, I did both. Mice, humans, I got them all. I love the placentas. I'm going to get a t-shirt that says placenta, gateway to a good life. I'm trying to get the SOGC to support that, but that's another talk. So you're bad for my ADD. Collaboration and partnerships we know will improve diagnostic capacity. We know that. We have to do this together. We're all in this together. And I think that being here in Ontario, them having no announcement, but a strategy is so important. It's incredible. You guys have been working toward this diligently for years, and I think that you should be extremely proud of where you are now in the field of FASD. You have great experts, great clinicians, great resources, great researchers. So it is so fantastic to have finally almost a strategy. I was on the expert advisory committee, so I actually do know there's a strategy. Collaboration, and so we know that we have to do it together. We can't do it alone. Miriam said we can't reinvent the wheel. There's no sense in that. Lots of folks are learning from each other. This field is so willing to share information and resources. Look how engaged the Public Health Agency is. I told Dr. Taylor he was starting to become an FASD groupie because he was there in Fredericton at our announcement. He's here. And he seemed to think that was a good thing. So I probably thought maybe I shouldn't have said that, but he was fine with that. So they're so engaged, and it's nice to have the federal support, the provinces, the clinicians, the families, the researchers. We're a small field, and it's amazing to be able to work together. And everybody has their own ideas. And a lot of people think their ideas are the right thing to do all the time. And listening to everybody's ideas and experiences is really, really a way to inform the practice of what we do. And I think the Research Network spends a lot of time bringing people together and having discussions so that we can start to really listen and understand what goes on in this country related to FASD from many different angles. So this is our Diagnostic Guidelines Committee, repeated from 2002. When we started, we added some more psychologists because we knew psychology was so important. So we have Ab Chudley, Ted Rosales, Valerie Temple, who's from Ontario, Mary Ellen Baldwin, Courtney Green, Nicole LeBlanc, Bernie Mallon, Audrey McFarlane, Christine Lilly, Julie Connery, me having a really bad hair day and being up a few pounds, Christine Locke, and Jan Lutke. And so these were the workhorses that were really behind the diagnostic guidelines. They did so much work, put so much of their own time as volunteers to do this, and have so much experience and expertise between them, as well as their linkages internationally. And you can also read in the guidelines themselves where we did acknowledge all the international folks who provided input. So we're hopeful that the guidelines are going to inform practice. Hopefully within 3 weeks, we'll have released an online training program related to diagnosis for diagnostic centers. We're piloting it on April 4th. We think it's about ready to go. And so now the Canada FASD Research Network has an online learning platform, which is going to be really exciting. And so when we want to start to develop online courses and training, we have a place to house it. And so this will be our first release, and that was supported by Alberta, actually. So that'll be coming out, as well as the Family Advisory Committee's companion paper. We submitted some abstracts to the Canadian Pediatric Society, who actually rejected our abstract on the diagnostic guidelines, which I was really surprised about. But nonetheless, we're trying to kind of start to do some education and training related to diagnosis. So thank you. Was I on time?